Hi, I'm Megan.
Hi, I'm Laura.
Today we're going to talk about regional anesthesia and local anesthetics. The use of regional anesthesia and neuraxial anesthesia seems to be gaining traction lately, and there are many reasons why anesthesia providers are turning to regional anesthesia as compared to general.
I think patients really like it.
Yeah.
I mean, I know when I broke my arm, I was really happy to have a block. So then I didn't have to worry about getting intubated.
Yeah.
And all the side effects from the other medications. And I just had sedation. It was great. And then I had some post-operative pain relief also.
Absolutely. So there's reduced risk of nausea and vomiting because you're cutting out the opioids, you're cutting out the narcotics. There's a lot less postoperative cognitive dysfunction in the elderly population because they're not being exposed to the anesthesia gases. You also have more cardiovascular stability when you're not doing systemic anesthesia. There's actually a lot of evidence out there that says it reduces post-op surgical site infection. There's greater patient satisfaction as you use it experienced. And there's actually even evidence out there that says when used during cancer surgery that there's less recurrence as compared to general anesthesia.
Wow.
I know, it's amazing. So regional anesthesia is becoming safer because we have better ultrasound machines. So it's definitely worth consideration when you have a patient that's eligible for it. But no technique is perfect, and we know that local anesthetics come with their own host of problems.
Although there are many benefits to regional anesthesia, there are some risks. In order to understand these risks, first let's review some pharmacology. As everyone remembers, local anesthetics exert their action by reversibly inactivating sodium channels, blocking signal conduction along the axon.
Okay.
All local anesthetics used in practice have a similar structure, consisting of a lipophilic group, a hydrophilic group, and a linking chain.
So it's the linking chain that determines whether or not the local is an ester or an amide.
Exactly. So the drug is deposited extracellularly and exists in equilibrium between the unionized form and the ionized form. Now, only the unionized form can cross the cellular membrane. After the unionized form crosses the membrane, it needs to conjugate with a hydrogen ion in order to bind to the receptor on the sodium channel.
Okay, so it works on the sodium channels.
Yep, that's the site of action. Exactly.
Great.
Local anesthetics, there are some adverse effects. And the first we'd like to talk about are the allergic reactions associated with local anesthetics.
Now, I always wondered about that because I have very frequently on patients list local anesthetics as an allergy, whether it be Novocaine, lidocaine, and I always wonder, how much of that is a true allergy.
Right. The local anesthetics can produce an allergic reactions, but the incidence is very low.
That's good to know.
So it probably is, it may require further investigation.
Okay.
Amino esters, such as chloroprocaine, have a greater incidence because they are derivatives of the compound para-aminobenzoic acid. So if patients do have a true allergy to esters, they should be treated with a preservative-free formula of amide, local anesthetic, to avoid reaction to PABA or methylparaben.
Okay, well that's great to know.
So, I think that the actual allergies to the amides is incredibly rare. But if they do have testing that shows they do have an allergy, you're kind of, there is some cross-sensitivity between the two of them. So,
but it's often the preservative and not the anesthetic.
Exactly.
Great.
That brings us to methemoglobinemia.
Say that 3 times fast.
All right, this is a side effect unique to the local anesthetics. It has been associated with prilocaine administered topical, epidural, or IV. And metabolism of the prilocaine by the liver produces orthotulidine,
yikes,
which converts hemoglobin into methemoglobinemia.
So it's
methemoglobin.
It's the metabolite. It's not the actual local anesthetic.
Right. Well, the liver produces this metabolite, which converts the hemoglobin to the methemoglobin.
Wow. I've seen it.
Oh.
It's pretty scary. the patient, desats, right? Which is probably one of the first side effects
Right?
with benzocaine spray.
Right, okay. And did you have to treat it?
Yeah, we treated it with methylene blue.
Oh, very nice.
Yeah.
Did it affect the patient's saturation?
Well, the saturation was already affected from the methemoglobinemia, so the methylene blue made them desat a little further, but then everything resolved itself.
Right, because it says in most patients, it's well tolerated. You have to be concerned in patients that have severe anemia or heart failure, because they usually cannot tolerate the decreased oxygen carrying capacity. Actually, in some countries, prilocaine is completely banned because of this.
Really?
Yes.
Wow.
But anyway, the methemoglobinemia, it usually produces a brownish gray cyanosis, tachypnea, and metabolic acidosis. Loss of consciousness can occur in 50 to 60% of the patients. Wow. But it will spontaneously reverse itself in 2 to 3 hours.
Really? So once the metabolite disappears, then...
And like you said, the administration of methylene blue, 1 mg per kg, can result in immediate reversal.
So it sounds like in a healthy person, hemoglobinemia could probably even go unnoticed.
Right. But one population, actually obstetric patients, there is a concern because clinical doses could cause a 10% conversion of fetal hemoglobin to this methemoglobin, and that could lead to neonatal cyanosis.
Oh, wow. So not good for use in obstetrics.
Right. No
right.
prilocaine in obstetrics.
Don't do it.
Laboratory models have demonstrated that all local anesthetics have neurotoxic effects. And
yet, we bathe our nerves in them.
Right. But they are, in some ways they can be neurotoxic.
Okay.
I mean, they work, and we're lucky that a lot of times they are, they are on and then they're off, and they're not in the area for a long time due to our metabolism elimination.
Okay.
But if there is a duration of exposure that is longer, that may cause a damage to a nerve membrane.
Oh, okay. Interesting.
And there shows to be a lot of variations in neurotoxicity between different agents.
Really?
So, and we know this because we've seen, you've heard of Cauda-Equina syndrome.
Yes, absolutely.
And that was actually attributed to 5% lidocaine.
Yes.
Okay, so no longer, you no longer see 5% lidocaine on the market. The highest you see is 2% lidocaine. And that's actually, over time, the concentrations and doses have decreased.
Okay.
And that is really, really in hopes to prevent nerve damage. Another thing about local anesthetics I didn't know, they have vasoconstrictive properties.
In and of themselves?
Yes.
Oh, I didn't know that either.
And this, of course, can, potentially damage a nerve through ischemia.
Oh, okay.
And then you're potentially adding epi.
Correct.
And that is another vasoconstrictor. And, that's also decreasing blood flow. So that could also cause damage to a nerve.
So not only is the drug itself neurotoxic, but we're also restricting blood flow to the nerve and damaging it in that way.
Yeah, potentially. Now, this is all potential.
Okay. We use this all the time.
Right. This is all, they say that these are things that could occur. And, you have to be careful in the patients that may have some disease states, such as diabetic neuropathy, peripheral vascular disease. And these things can make the integrity of the nerves more susceptible to injury.
Okay, so people who are inclined to nerve damage in the first place, maybe you want to give a second consideration before doing some regional anesthesia on them.
Right, exactly. So we have talked about how regional anesthesia, is
wonderful,
a great option.
Also has some drawbacks.
It does have some drawbacks, but most of them are pretty mild. That methemoglobinemia, there is a treatment.
Yeah.
And that it can be reversed easily.
And we now know that allergic reaction is rare.
It's very rare, and if there is a potential reaction to the esters, then you pretty much can use a preservative-free amide.
And how about anaphylaxis? Is that a concern?
Anaphylaxis is not. It's the studies have shown that although they may have some skin reactions to the local anesthetics, anaphylaxis was not shown.
Never seen.
So,
okay. Well,
so
that's
although
comforting.
there may be allergic reactions to these local anesthetics, but anaphylaxis is very rare, incredibly rare. So
Good to
anyway,
know.
but the biggest problem with local anesthetics is a complication called local anesthetic systemic toxicity, and it's commonly referred to by the acronym LAST, and this can lead to seizures and cardiovascular collapse.
Oof.
So mild LAST occurs in about 1 in 1,000 patients, which is
That's more common than I would expect it.
right. That's like what we do probably in a week. Severe LAST occurs in approximately 8 to 25 per 10,000 peripheral nerve blocks and 4 per 10,000 epidurals.
Wow. So not as common, but still occurs more frequently than we're probably comfortable with.
Right, right. So that patient that you might have said, wow, that Versed worked really good. I cannot believe he is that sleepy off a 2 of Versed, with a nerve block. He actually he might be showing some symptoms
Wow.
of local anesthetic toxicity.
Tell me more.
So anyway, it is not a common event, but the severe LAST is not a common event, but it can have catastrophic consequences.
Seizure and circulatory collapse don't sound like a picnic to me.
No, not something I want to be doing 8 a.m. on Friday. Anyway, most common causes of LAST are inadvertent intravascular injection of the local anesthetic, a rapid administration, and administration of an excessive dose. Factors associated with local anesthetic toxicity. The local anesthetics with greater potency, such as bupivacaine, can cause a toxicity at lower plasma concentration. And I know a lot of the studies I looked at, a lot of them talked about bupivacaine.
That's the bad
and
one, right?
cardiotoxicity,
Yeah.
and it's just because it's such a potent agent. I think it has its benefits, of course, but it tends to lead right to cardiac collapse.
So
If
bypasses
not
the
used-
neurogenic right into cardiovascular.
Right. So another factor that's associated with local anesthetic toxicity is the speed of absorption into plasma, the total plasma concentration, which would be the milligram per kilogram dose, and there are also some of these patients aren't able to metabolize the drug.
Right.
So especially the aminoamides, they're metabolized by the liver. So in somebody that may have hepatic disease, they may not have the ability to metabolize these agents, so they're going to stick around longer.
What about, Laura, patients who have low protein states, like hypoalbuminemia?
Right.
Since these drugs are so highly protein bound, does that affect?
Oh, definitely. There's more free drug.
Yeah.
So that could lead to, more drug in the system, potentially causing toxicity. So Megan, what are some symptoms your patient may report if they're experiencing some mild local anesthetic toxicity?
I've had people say they have a metallic taste in their mouth.
Yeah.
Some reports of ringing in the ears.
Right.
Some circumoral numbness.
Very good.
Dizziness, lightheadedness. But these are all pretty benign symptoms.
Well, no, these are mild symptoms, or mild to moderate, of local anesthetic toxicity. So these are something, you want to, if this is something that's happening, you want to really be paying attention to your patient, because it could worsen. And also remember that you're giving your patient sedation, and that may obliterate the ability of the patient to tell you
That's true.
that they're having these symptoms. So it's really important while you're doing a block to be talking to your patient and continuing assessing your patient while you're doing the block. So what are some signs of severe neurological toxicity that you think you may encounter?
Well, of course you'd be concerned if they become unresponsive or unconscious.
Right.
That seems like it would be a pathway to something even worse.
Yeah. And seizures, that's always pretty sure sign that you have something going awry.
Yeah.
And so, basically it is coma, seizures, unconsciousness, respiratory failure. The brain is actually more sensitive to the effects of elevated plasma concentration of local anesthetics than the heart is.
Oh, okay.
So this is why you oftentimes see neurological symptoms initially.
Okay.
And then these progress until finally you have some cardiotoxicity. Very high levels of local anesthetics will affect cardiac electrophysiology and our contractility, and this could lead to cardiac arrest, dysrhythmias, VFib, and VTAC. So there was a whole meeting about this, and the American Society of Regional Anesthesia and Pain Medicine noted that the presentation of LAST is different from the classic textbook presentation.
Oh, really?
So the feeling is that these mild subjective symptoms that progress to severe symptoms.
Right, because we were all taught this pyramid, right? You saw the pyramid, and at the bottom of it was metallic taste in your mouth, and at the top of it was
Seizure.
coma and seizure.
Right.
Yeah,
Exactly.
So they're saying that this isn't necessarily.
This is not necessarily what happens in this situation. Less than 40% will present with this.
Wow.
So, I mean, of course,
That's
it's good to be prepared if you see some mild symptoms, but unfortunately, many patients will proceed directly to seizures. And then fewer, like I said, because the heart is not as sensitive to the local anesthetic effects.
Okay.
But then fewer will just go straight to cardiac toxicity. But most patients, it's been found that will present 5 to 30 minutes after administration with vague signs of altered mental status, bradycardia, and hypotension. The American Society of Regional Anesthesia and Pain Medicine developed a checklist which can be easily obtained from their website. They strongly recommend using this checklist and having a local anesthesia toxicity kit ready. So wherever regional anesthesia or any kind of local anesthesia, regional or central anesthesia is going to be given.
Okay. So what are we gonna do? What does the checklist tell us to do?
The first thing on the checklist would be to call for help.
Okay.
Because at this point, this is most likely a local anesthetic systemic toxicity situation. So now you need to optimize your oxygenation, ventilate with 100%, and determine if the patient needs to be intubated.
Okay.
This is very critical in the setting of local anesthetic toxicity to maintain your acid-base status.
All right.
Any increase in CO2 causes an increase in cerebral blood flow and could introduce more local anesthetics to the cerebral circulation. So diffusion of carbon dioxide across the nerve membrane can cause intracellular acidosis, and this may promote conversion of the local anesthetic into the positive active form.
Wow. So it becomes a vicious cycle, basically.
Right. So it's very, very important to effectively ventilate your patient.
Okay.
So that acidosis does not occur. Acidosis also could lead to ion trapping because the positive form of the ion cannot travel across the nerve membranes. And hypercarbia also results in reduced binding of local anesthetics by plasma proteins, and more drug is available.
So you got more drug in the bloodstream, more drug affecting the brain tissue, and so it's
very critical in this stage to maintain oxygenation.
Okay.
And effectively ventilate so your CO2 levels stay normal. Seizures need to be suppressed, and benzos are the preferred drug class in the last scenario. Propofol should not be used, and I was actually thinking about that. Like, what about propofol?
Yeah.
But propofol does not have the lipid content high enough to provide any benefit.
Okay.
And it also is a cardiac depressant, so that would not.
So when you're already
be
faced
beneficial.
with myocardial insufficiency,
Or potential cardiac insufficiency at this rate. At this rate, you're already a patient. If your patient's seizing, they potentially could go to become cardiotoxic. So you don't want to be giving them anything that's a cardiac depressant at that point.
That makes sense.
Next on the checklist is to manage the cardiac arrhythmias.
So you talked a little bit about tachycardia and then a wide QRS. Is that what we should expect to see?
Right, but the thing with LAST is that the classic ACLS algorithm does not really apply to these patients. A lot of medications such as beta blockers and calcium channel blockers are actually they could further depress the cardiac system.
Okay.
So we don't want to use those. Actually, animal studies have shown that vasopressin and epi have also been counterproductive in the treatment of LAST.
So what are we going to do? What are we going to reach for?
So you can still, with hypotension, you can still use epi, but it's recommended to use low dose, like 1 microgram per kilogram.
Oh, okay.
Well, the key component of the checklist is the lipid emulsion therapy. And the mechanism for this it's called the lipid sink theory.
Okay. So this has to do with the lipid solubility of the local anesthetic.
Exactly. So the lipid solution creates a lipid compartment within the plasma, and this actually remains separate from the aqueous phase of the plasma.
Okay.
And so the lipophilic, like local anesthetics, are deposited into this separate lipid sink, and this actually reduces the concentration of local anesthetics in the system.
So there's no longer systemic local anesthetics. They're all sitting within the lipid sink that's within the bloodstream, and the local anesthetic is no longer available to cause any neurological or cardiovascular side effects.
Right. Earlier reports utilizing lipid infusion for patients with LAST focused on patients that were already in asystole. More recent cases show clinicians using lipid infusion to diffuse local anesthetic toxicity before it reaches climax.
Okay.
Patients with LAST typically present with a similar course of symptoms.
Okay.
It's tachycardia, and then there's a widening of QRS, tonic-clonic seizures, and then asystole. In the case of LAST, you may need to perform CPR and also acknowledge that prolonged efforts might be needed. And it's crucial to maintain circulation until the local anesthetic is redistributed or metabolized below the level associated with cardiotoxicity.
Some of these local anesthetics have a really long duration of action, though. So are people using bypass for this instance?
Yes, it is actually very important, and that is on the checklist to alert the nearest facility with cardiopulmonary bypass capabilities.
Okay, so
it's
if
very
you can't do it
important
yourself,
because
then
you don't know how long this is going to take, and it may, like you said, take they may need to do this until the local anesthetic effects are worn off. So recovering from LAST associated with cardiac arrest may also take, CPR might take more than an hour.
Wow.
So you have to be. This is not a typical ACLS, condition.
Right. Right. You can't give up.
Right. Treatment of arrhythmias. Amiodarone is the drug of choice for arrhythmias, and avoid using lidocaine. And I remember I saw that, I was like, oh, that's kind of counterintuitive, but it's not counterintuitive, but it sounds kind of like, of course, but then lidocaine is actually used to treat.
It's in the ACLS protocol.
Right.
Yeah.
So, but you just definitely don't want to use it because it definitely could add to the toxicity. In the case of torsades, you may need to use overdrive pacing. So, that brings us to more regional anesthesia and anticoagulants.
Yep, coming up next, the confusing world of anticoagulants.
Exactly.
We know that the use of regional anesthetics is on the rise, and with improving ultrasound technology, it's getting safer than ever. However, also on the rise is the use of anticoagulants and other drugs that affect hemostasis. Our population is aging, and the aging population is getting bigger by the day, and indications for anticoagulation is also growing. Not only are our patients taking it for pre-existing conditions, but now we're using them to prevent post-op thromboembolism. So everywhere you look, there's anticoagulants. The concurrent use of blood thinners and regional anesthesia are putting our patients at an increased risk of hematoma. Hematoma in and of itself isn't necessarily a scary thing, but when they occur in the spinal region, either epidural hematoma or spinal hematoma, then it can be catastrophic. People who have epidural hematomas can have spinal cord ischemia, and the nerve damage there can be permanent and result in paraplegia. There are several cases of hematoma reported in anticoagulated patients who have received either neuraxial anesthesia or regional anesthesia, And but for the most part, the peripheral nerve block, the hematomas are self-limiting. They get confined in a certain space. They cause temporary nerve damage, but once the hematoma resolves, usually the nerves are able to return to their full functioning. Larger hematomas have been reported in some of the deeper sort of plexus blocks, and there have been several case reports of retroperitoneal hematomas, and the patients either required blood transfusion or in one case there was a death because of excessive blood loss. But I think the most concerning thing for most anesthesia providers is the epidural or the spinal hematoma. The incidence of it is relatively low in patients who are not anticoagulated. It's 1 in 450,000. But patients who are high risk, and that includes patients who are anticoagulated, elderly patients, or people with coagulopathies, the incidence can be as high as 1 in 4,000.
I don't know about you, but I'm finding it more and more difficult to keep up with all the new anticoagulants. Not only the anticoagulants, but the antiplatelets, antithrombotic agents.
Every time I turn around, I feel like there's a new one coming out, and trying to keep up with their mechanism of action and their duration of action is really hard. But fortunately, we have someone who can help us. The American Society of Regional Anesthesia, or the ASRA, who you discussed earlier today, they have guidelines for performing regional anesthesia on patients who are anticoagulated. Their guidelines are a little old. They come out in 2010. It's the 3rd edition. But their most recent publication is actually more geared towards patients with interventional spine and pain procedures.
Oh, okay.
But there's a lot of new information in there that I think we can utilize and extract from that for patients that we're going to do peripheral nerve blocks on, and just simple neuraxial anesthesia procedures like spinal anesthesia and epidural anesthesia. Our goal in this segment is to review those guidelines, both the new and the old, with you guys. But first we have to do a little review on the dreaded hemostasis. When we talk about coagulation, we are really talking about 2 processes: primary and secondary hemostasis. Primary hemostasis is triggered by an injury to the vessel wall. Each vessel has 3 layers that serve a different function when it comes to hemostasis. When a blood vessel is damaged, the first layer of the vessel, the endothelial lining, secretes tissue factor, otherwise known as thromboplastin or factor 3. Tissue factor is the primary trigger for secondary hemostasis, but we will get to that in a minute. Von Willebrand's factor is also secreted from the endothelial lining, which we will represent here with a little blue hook. Von Willebrand's factor is also secreted from the platelets and helps platelets stick to the endothelial lining and to each other. The second layer of the vessel contains collagen and fibronectin. When collagen is exposed, it creates a sticky surface for the platelets to adhere to. Once the platelet adheres to the collagen, a signal is triggered and the platelets become activated. Activated platelets transform into a star-like shape. When fibronectin is exposed, it creates a surface for the fibrin to attach to. Fibrin is already floating in the blood in small amounts, but it is the end product of the final common pathway in secondary hemostasis. Fibrin production greatly increases when secondary hemostasis is initiated. The adhesion of platelets and fibrin create the initial hemostatic plug. The third layer of the vessel, the muscular layer, contracts to slow down the blood so as to not dislodge the clot. This is the completion of primary hemostasis. Let's take a closer look at the role of the amazing platelet. This is where a lot of our drugs work. Each platelet contains a number of procoagulant substances that spill out during the activation process. ADP, von Willebrand's factor, serotonin, platelet activating factor, platelet factor 4, thromboxane A2, epinephrine, histamine, and ionized calcium are all necessary components of platelet aggregation. This chain reaction also results in increased glycoprotein receptor affinity to fibrinogen, which is a precursor to fibrin. This helps create the mesh network of fibrin and platelets known as the hemostatic plug. This is the reaction site of many of our antiplatelet drugs. NSAIDs, for example, inhibit cyclooxygenase 1, also known as COX-1. COX-1 is the precursor to thromboxane A2. when thromboxane A2 is inhibited, it reduces platelet activation and aggregation. Aspirin inactivates COX-1 for the lifetime of the platelet. Other NSAIDs, like ibuprofen, only inhibit platelet function for 3 to 4 days. Another type of antiplatelet medication are the thienopyridine derivatives. The most commonly used drug in this class is clopidogrel, otherwise known as Plavix. These drugs work by inhibiting ADP, which facilitates platelet fibrinogen binding. There are also several frequently used herbal medications that exert an effort on platelet aggregation. Garlic inhibits platelet aggregation in a dose-dependent fashion. Ginkgo also inhibits platelets and has been known to cause spontaneous intracranial bleeding. So now that we've looked at primary hemostasis, let's move on to secondary hemostasis. The purpose of the coagulation cascade is to manufacture large amounts of fibrin in order for coagulation to occur. Fibrin is the end product of the final common pathway. Clotting enzymes exist in the bloodstream in an inactive form known as zymogens. Once an enzyme is activated, it creates a chain reaction and activates the other zymogens in the pathway. The extrinsic pathway is activated when tissue factor is released from the middle layer of the blood vessel. Tissue factor activates factor 7. Activated factor 7 interacts with factors in the platelet, primarily calcium, to activate factor 10. Activated factor 10 and activated factor 5 join forces in the final common pathway to turn prothrombin into thrombin, which is also known as activated factor 2. Thrombin, in turn, changes fibrinogen into the stronger and insoluble fibrin. The intrinsic pathway is initiated when collagen exposure activates factor 12. 12 activates 11, which then activates 9, then 8. Factor 8 interacts with the platelet to activate factor 10, and the final common pathway is triggered again. Let's look at how our anticoagulates work on the clotting cascade. There's a group of anticoagulants out there that work specifically on thrombin called direct thrombin inhibitors. They inhibit both free and clot-bound thrombin. The drug with the trade name Pradaxa, or dabigatran, is the most commonly used direct thrombin inhibitor. It is also the first of the newer generation anticoagulants that can be completely reversed. Coumadin works by inhibiting vitamin K receptors in the liver, making it unable to produce thrombin and factors 7, 9, and 10. The newest group of anticoagulants work specifically on activated factor 10. They have the trade names Atrixa, Xarelto, and Eliquis. There are several negative feedback mechanisms in place to prevent your blood from clotting in excess. Some of our anticoagulants work by activating this system. One of these negative feedback mechanisms is called antithrombin. Antithrombin is always active and its job is to inactivate thrombin. It also works on most of the intrinsic pathway by inactivating factors 12, 11, 9, and 10. Heparin works with antithrombin to accelerate its ability to inactivate thrombin and factor 10. Fibrinolysis is another component in this negative feedback system and occurs primarily via plasminogen. Plasminogen is made in the liver and is always present in the blood. It is built into the fibrin clots, then gets converted to its active form, plasmin, by TPA. The job of plasmin is to cleave fibrin into unusable parts. This is where thrombolytics like streptokinase and urokinase work. They are classified as plasminogen activators and are better known as clotbusters. You meet a patient the day of surgery. They're scheduled to have either neuraxial anesthesia or a peripheral nerve block, but you notice that they're routinely taking anticoagulants. How do you determine if they've been off their anticoagulant for long enough and it's safe for you to provide them with regional anesthesia?
Well, I think when you talk to the patient, and oftentimes they'll report to you how long it's been. And then you need to compare that to the guidelines from ASRA.
Yep, ASRA has a really comprehensive list of anticoagulant, antiplatelet medications. And they'll tell you exactly how long the patient should be off of these medications. And that's probably your best resource. There's actually even apps out there that'll tell you how long the medication should be stopped before safely providing them with this type of anesthesia. Their newest edition, the 2015 guidelines for interventional and spine anesthesia and procedures, talks a little bit about some steps that you can take that aren't necessarily drug specific, but can also help you make a really accurate determination of when it's safe to provide your patient with regional anesthesia. One of the concepts that they introduced in their new guidelines is the idea of risk assessment and risk stratification. And basically what they're asking you to do is weigh the risk of stopping the patient off their necessary anticoagulant or antiplatelet drug and the risk of hematoma. And that's usually a multidisciplinary approach where you would discuss it with their cardiologist, whoever put them on the anticoagulant in the first place, and looking at the risk of the procedure and how detrimental it would be to the patient's health if they had a hematoma. Peripheral nerve blocks are considered low-risk procedures, and spinal and epidural anesthesia is considered intermediate risk anesthesia. And we know also that epidural anesthesia has an increased risk of spinal hematoma as compared with spinal anesthesia. One area where this is relevant is when considering aspirin. In the past, aspirin was not considered a risk for either neuraxial or peripheral nerve blocks, and the 2010 ASRA guidelines do not recommend stopping aspirin for either one of these procedures. But aspirin has come under scrutiny again. Its effect on hemostasis, as we saw in our review, is multifactorial, and it not only does it inactivate COX-1 for the duration of the platelet life, but it also works on secondary hemostasis by decreasing thrombin formation. This recommendation for risk stratification talks about why some patients are taking it for primary prophylaxis, just, you're after a certain age, you take a baby aspirin, but some people are on it for secondary prophylaxis. Someone who has a history of a valve abnormality or AFib or something like that, who are at risk for thromboembolism, those patients, stopping aspirin in them might not be so smart. In fact, there's some studies that show out there that cardiovascular events, 10% of them are preceded by aspirin discontinuation.
Oh, wow.
So it's not always a great idea to discontinue aspirin, and we know it's not necessarily going to cause a hematoma in all of our patients, but the new guidelines sort of ask us to consider, if this patient gets a hematoma, how damaging it would it be, and compare that risk with what the risk of a cardiovascular event would be if you de-seed their aspirin. So it's putting it back into the practitioner's hands a little bit. It's asking us to weigh the risk versus the benefits, and I think that's a really important take-home from the new guidelines.
So you're looking at the whole picture.
Looking at the whole picture, and you're taking it patient by patient basis. Another really interesting concept is that they introduced is the concept of the 5 half-lives. We all know that 50% of a drug is eliminated after 1 half-life. And when you get down to 5 half-lives, there's only 3% of the drug left. And that's sort of what they base a lot of their recommendations on, is waiting the 5 half-lives. Some countries they recommend waiting 2 half-lives where there's only 25% of the drug left active. But ASRA takes it a step further, and they say 5 half-lives is probably the Goldilocks period where you're going to get the maximum benefit of waiting this amount of time. So there's a lot of new drugs out there that we don't have a lot of information about when it comes in terms of, spinal hematoma and hematomas when it comes to regional anesthesia, because you simply can't expose subjects to that kind of study.
Right, with these new agents.
All the new agents, the new antiplatelet agents, and a lot of agents that work on factor 10. So their guideline is based on the 5 half-life theory. So, and that's a really quick and easy thing to do. If you can't find the guidelines, if you're not able to get this recommendation for this certain drug or even new drugs that come out, the 5 half-life theory is what they sort of base a lot of their information on. As if it's not hard enough to contend with keeping up with all the new anticoagulants and deciding whether or not it's appropriate time to do regional and neuraxial anesthesia, there's a lot of other drugs that sort of have hidden antithrombolytic properties. And one of them of interest and brought into the forefront with these new guidelines are the use of SSRIs.
A lot of patients are on SSRIs.
Almost everybody.
Yeah, I mean, you do see them very frequently.
And it actually increases the bleeding risk as much as NSAIDs do.
Wow.
In and of themselves, it's not recommended that they be stopped before regional or neuroaxial anesthesia, but they do potentiate the other anticoagulant drugs. So it's important to know that these patients are at increased risk. In fact, patients on SSRIs, when they take a study of patients who are getting brain surgery, breast surgery, and spine surgery, that increase the need for transfusion by 4.
Oh, wow.
A factor of 4. So it's not insignificant. They don't recommend stopping them. Obviously, the risk of stopping SSRIs is greater than the risk of, perhaps performing a peripheral nerve block, and the bleeding risk is relatively low. But if you have a patient who's taking multiple medications, and some of them are antiplatelet or anticoagulant, and on SSRIs, then you might want to consider having them off of their antiplatelet drugs for a lot longer, or longer than the 5 half-life idea. And then there's yet another source of drugs that have anticoagulant activities, and those are sort of drugs that are not prescribed, but a lot of our patients on. And these are the herbal medications. How many patients do you have that are on herbals?
Oh, I see it all the time. I can tell you most patients are very good about stopping them because they are aware of this, or their doctors tell them to stop them, and oftentimes they're off of them for about 2 weeks. But I do know that garlic can cause does it impact platelet
It
aggregation?
does, yeah. Garlic actually does impact platelet function. And, the recommended dose of garlic is actually the equivalent of 2 cloves a day. And people are taking this in extract form. But there's actually one case report of an elderly gentleman, I think he was in his 80s, who had a spontaneous epidural hematomia, not even with any sort of procedure at all, but he was taking so much garlic that his platelet activity was so impaired. And platelet function tests returned to normal after a week of no garlic use. So this is a real concern. Ginkgo biloba is also another one that we have to worry about. That has antiplatelet properties, and drugs like Donkai.
I haven't seen too much of that one.
No, and Dashin.
No, not too much. Garlic is very common though.
Garlic is common. And I will tell you that Dashin is actually in Chinese medicine used to improve the heart. Okay, it's used to heal the heart. Now, a lot of patients, especially in Chinese descent, after they have heart surgery, their families put them on this drug because they feel like it's going to improve their recovery. However, it interacts with Coumadin, and it increases their INR by 3-fold.
Whoa.
So they've had a lot of patients who come back from cardiac surgery and they're bleeding. They're normalized on their INRs become normalized on the Coumadin, and then the families try and help and heal their hearts by putting them on this medicine, and they're actually doing them a lot of harm. So these drugs should be stopped because in and of themselves they don't necessarily cause enough bleeding risk to cause problems, but because they're not FDA approved, it's impossible to tell how much of this drug each person is getting. So that's why we do the blanket recommendation of, most people tell them to stop it a week or 2 in advance. Laura, thank you for coming. It was so fun to talk about local anesthetics and regional anesthesia and the benefits and the drawbacks.
And anticoagulants, don't forget them, and how they just keep sneaking up more and more.
Yeah, and how
we have to be careful.
Impossible to keep up with, but we're going to keep you in tune to what's going on. So tune in next time to Inotrope Anesthesia, and we're going to make sure you know what to do.